Welcome to the Society of Obstetrics, Anesthesia, and Perinatology hosted virtual webinar on the impact of iron deficiency and associated symptoms such as heavy menstrual bleeding or abnormal uterine bleeding in women related to reproductive health, pregnancy, and overall quality of life. This is a CME-sponsored event courtesy of Medicus and produced by the Women's Health Research Collaborative, an independent research subsidiary bringing women's health issues to the forefront. Today's guest speakers are Dr. Malcolm Munro and Dr. Richard Derman. Dr. Munro is a clinical professor in the Department of Obstetrics and Gynecology of the David Geffen School of Medicine at UCLA and is on the staff of Kaiser Permanente's Los Angeles Medical Center. His clinical and research interests are oriented to disorders of the uterus, adnexae and surrounding structures including diagnosis, medical management, and, when needed, minimally invasive approaches, be they hysteroscopic, laparoscopic, vaginal, or image-guided. Dr. Derman is the Associate Provost for Global Affairs, Professor of Obstetrics and Gynecology, and Director of Global Research at Thomas Jefferson University. He has served in academic leadership positions at 4 leading U.S. institutions. Dr. Derman's recent research and subsequent publications have proven instrumental in scaling up global initiatives for clinical conditions such as postpartum hemorrhage, iron deficiency anemia, and the prevention of preterm birth. At the completion of this CME-accredited program, clinicians will be better able to utilize evidence-based practice related to iron deficiency and iron deficiency anemia, IDA, in reproductive-aged women, including those who are pregnant. Implement evaluation and management strategies informed by clinical differentiators and patient preferences related to the treatment of women with IDA. When thinking about evidence-based approaches to patient care, Dr. David Sackett defined evidence-based medicine as the conscientious, explicit, and judicious use of best evidence in making decisions about the care of individual patients. Today's virtual CME accredited program will cover 3 topics related to the prevalence of iron deficiency and iron deficiency anemia. First, the global impact of iron deficiency and iron deficiency anemia. Next, we will highlight the impact of IDA on healthy reproductive-aged women, as well as the impact on pregnancy and the developing fetus and child. Finally, we will share best practices related to identification and management of IDA in both healthy reproductive-aged women and during pregnancy. To begin our discussion of the global impact of iron deficiency and iron deficiency anemia, Dr. Richard Derman will lay the foundation for why this is a global health concern.
The enormity and impact of low iron stores and anemia is an ongoing global challenge. During this CME lecture, I'll be focusing on the role of iron and how it impacts the mother and baby dyad. My colleague, Dr. Munro, will be discussing predictors of adverse outcomes among all reproductive-aged women with iron deficiency or iron deficiency anemia. Of the world's 7.75 billion inhabitants, about 2 billion individuals suffer from anemia. We recognize that reproductive-aged women are disproportionately affected, and this knowledge supports the theme of today's presentation. This slide depicts anemia prevalence worldwide in reproductive-aged women. The rates vary from 20% in the United States and in Western Europe to more than 40 to 60% in sub-Saharan Africa and Asia. The CDC, Centers for Disease Control, estimates that 30% of all non-pregnant reproductive-age women worldwide are affected. The number of women with anemia that is depicted on this map are derived from a WHO survey conducted in 119 countries and are therefore only estimates. These data reflect overall anemia rates, but do not include the large number of individuals who are iron deficient but have not yet reached the anemia threshold. Pregnancy is often the first time in a woman's life that she may get screened for anemia. The combined iron demands in pregnancy of both mother and fetus are manifested by its high global prevalence. Not surprisingly, those regions of the world that have the highest rates of anemia in the non-pregnant population also have the highest rates among pregnant women. Because screening for anemia is not a usual practice, even in reproductive-aged women, the number of women that are actually iron deficient is not known. Categories of anemia are highlighted in this slide. Among all women suffering from anemia, the majority, that's estimated to be about 70%, is caused by iron deficiency. This is especially important in pregnancy when iron demands are higher. There is an estimated 50% global prevalence rate. Pregnancy may simply push those with pre-existing iron deficiency into an anemic state. Despite the increased maternal and fetal need for iron, additional oral iron requirements are not present until the second and third trimesters of pregnancy. In fact, because pregnant women have ceased menstruating, daily iron requirements are actually reduced during the first trimester. And yet the strongest correlation with anemia and poor pregnancy outcomes occurs when anemia is recognized in the first trimester. Most likely, these women are entering pregnancy already iron compromised. In pregnancy, there are acute physiologic changes that occur in a woman's body and a dramatically increased need for iron during the second and third trimesters of gestation. These changes include an increase in plasma volume and an increased red cell mass. Women require 4 to 5 milligrams of iron daily during the second trimester of pregnancy, and more than 6 milligrams in the third, the times when fetal growth and brain development are maximal. Brain development being maximal in this late second trimester and fetal growth in the third trimester of pregnancy. Iron demands also need to account for placental storage and blood loss at the time of delivery. It's estimated that the total requirement of a woman during her pregnancy is 1 to 1.2 grams of iron. Later in this presentation, I'm going to spend a few moments describing the clinical impact of maternal anemia and fetal underloading and its very serious sequelae. What is perhaps not fully appreciated is that low iron stores and iron deficiency anemia represent an intergenerational problem. If a woman enters pregnancy being iron deficient, the likelihood is that she will become even more iron depleted, setting up a circular pattern of low iron from mother to fetus to child through adolescence and often into the next pregnancy. And while other micronutrient deficiencies such as vitamin A, B12, and folate are confounders, diagnosis and treatment of iron deficiency should remain a primary goal. We recognize that blood loss secondary to menstruation, and when a woman enters a subsequent pregnancy, tends to overwhelm the body's ability to effectively absorb and utilize sufficient iron. It's not surprising that women affected by iron deficiency anemia have significant increases in mortality and morbidity. Anemia in pregnancy is more frequently complicated by preterm labor, with increases also seen in placental abruption and in the rates of postpartum hemorrhage. We see an increase in intrauterine growth restriction, and perhaps most important, in impaired brain development in the offspring. While the subject of anemia rarely makes the headlines, it is 100 times more prevalent than cancer. We often focus on the 3 leading causes of maternal death: postpartum hemorrhage, hypertensive disorders of pregnancy, and infection. However, of the approximately 300,000 maternal deaths annually, 50,000 have been directly attributable to anemia, and a high proportion of the other deaths are confounded by the presence of anemia. and after delivery, increases in postpartum depression, fatigue, reduced cognition, and the ability to breastfeed all impact a woman's quality of life. These quality of life indices have all been shown to be negatively impacted by iron deficiency. Despite a large number of published papers by respected investigators, major organizations have been lax in establishing meaningful guidelines for screening and treatment. The most up-to-date standards, published in 2019, are seen in the United Kingdom, where the British Society of Hematology employs a simple equation of supply and demand, implying that pregnancy dictates an increase in iron demand that often cannot be met with standard oral iron supplementation. To quote Lord Kelvin, if you cannot measure it, you cannot improve it.
Thank you, Dr. Derman. In Section 2, Dr. Munro highlights the impact of ID/IDA on healthy reproductive-aged women, as well as the impact on pregnancy and the developing fetus and child.
We're going to talk about the pathogenesis of iron deficiency in reproductive-aged women. And for the purposes of this section, we're going to conflate these two groups, the adults and the adolescents, because really we can look at these women as one. And as part of this, we're going to, I think, show you that the issue of negative iron balance is really contributed to largely by the symptom of heavy menstrual bleeding and the resulting iron loss, as well as diet, depending on the individual. So let's start here. For non-pregnant reproductive-aged women, ID is linked to the balance between iron intake and menstrual volume. So if nutritional iron intake is equal to the iron loss, and assuming normal iron balance ahead of time, then ID and IDA generally don't develop. The normal menstrual blood loss is less than 80 mils and averages about 35 mils per cycle. But if the menstrual blood loss exceeds iron intake, iron deficiency and anemia will subsequently occur. So you can see here in this graphic, on the far left, the normal individual bleeding about 35 mils per month will lose about 1 milligram a day or 6 milligrams a cycle. But the woman who bleeds, say, 500 mils per cycle is losing 90 milligrams per menstrual period. And we're going to show you that this type of volume is perhaps more common than we have previously thought. So this brings up the question about what is heavy menstrual bleeding. And for practical purposes, we look at it as a symptom, not as a specific diagnosis, because the clinician, even the academically oriented clinician, doesn't have a way of quantifying volume. So the NICE guidelines, which is the National Institute of Care Excellence in the United Kingdom in 2007, defined heavy menstrual bleeding as that which is of a volume sufficient to adversely affect the woman's material quality of life. And we have high quality evidence that women who have this symptom, defined in the way we just did, have blood loss exceeding 100 mils per month. For example, in this study by Calaf et al., published 2 years ago, you can see that answering questions that define the symptom as we have is highly associated with a blood loss of more than 100 mils per month. So then, it shouldn't be surprising to understand that IDA in women in this age group who are not pregnant is most commonly caused by the symptom of heavy menstrual bleeding. And of course, that symptom reflects actual iron loss. And yes, there are other contributors nutrition, GI bleeding, etc. But the symptom of heavy menstrual bleeding is clearly the most common cause, especially in the developed world. So, how common is this symptom? And typical data from hospital systems, published data based on women coming to doctors and having their symptoms validated and then entered into a database, suggests that it's 2%, 3%, 10%. But when you go to women and ask them using that definition, it's much more common. This is an exemplary study published by Mark Schoep about 3 years ago on women in the Netherlands, almost 43,000. And you can see here that the prevalence of the symptom of heavy menstrual bleeding was in excess of 50%, far more common than most people perceive. So, by our contemporary definitions of heavy menstrual bleeding, the prevalence may be as high as 50%. Now, to better understand the impact of iron deficiency and by extension, iron deficiency anemia, let's start with a little bit of iron metabolism. So, the body has between 3 to 5 grams of iron. For most women, this probably translates into 3 to 4 grams. And the majority of this, about 2/3 of it, is in heme, erythrocyte iron. About 10 to 20% is stored as ferritin, and most of that is in the liver, although it may also be in the spleen and the marrow and other locations. It's also important to know that iron is involved in other structures and other functions. About 3 to 4% of iron is in myoglobin. And also, there are other locations, brain, heart, non-heme enzymes that are critically important for life. So when we start with our dietary intake of iron, it's absorbed in the duodenum, upper jejunum, and the typical individual who is non-pregnant, it'll be 1 to 2 milligrams per day. Dr. Derman will talk to you about pregnancy, but there is greater absorption in pregnancy. And there is very little opportunity for excretion of iron. In men, it's pretty much confined to skin, sweat, and some gastrointestinal tract desquamation. But additionally, for women, the major means by which iron is excreted is by menstruation. So, what happens to this iron? Well, after the life cycle of the red cell is ended, it's typically recycled. The iron is recycled typically in the spleen. So that then gets put back into the circulation and goes back into these various locations that we discussed. Now, we want to talk about hepcidin because this is an important entity to understand so that you can understand what affects iron absorption. And because hepcidin is incredibly involved in this control. So it's a peptide hormone synthesized in the liver, and it regulates iron metabolism by binding to ferroportin, which is critical for getting iron, for example, from the gut into the systemic circulation. So elevated levels of hepcidin inhibit iron absorption, or its release from ferritin stores in the liver and elsewhere. And in many ways, from an evolutionary perspective, hepcidin was designed to help prevent us from being overloaded with iron. So its synthesis is increased with higher circulating serum iron levels. For example, for 24 to 48 hours after oral ingestion of supplemental iron, hepcidin levels go up to inhibit further absorption. Hepcidin's also increased with inflammatory processes, so there are some mechanisms by which hepcidin is elevated in a way that is not conducive to absorption, even if it's needed. And hepcidin's decreased synthesis, of course, is when there are low circulating iron levels, such as more than 24 to 48 hours after oral ingestion, in cases of iron deficiency or tissue hypoxia. So it's important to understand that low levels of hepcidin facilitate gut absorption and release of iron from tissue stores. So what does iron do? It's not limited to hemoglobin. We mentioned myoglobin. It's involved in cytochromes, in other enzyme synthesis, and so it becomes essential for respiration, for oxygen transport, for DNA synthesis and repair, for mitochondrial function, for energy production, and cellular proliferation. So it's critical beyond heme. But important to understand, not only in the non-pregnant but the pregnant individual, is that iron is prioritized to the creation of heme at the expense of other functions or developmental requirements. So if we look at this graphic, where iron allocation is essentially normal, the woman's in normal iron balance. So iron is directed to the formation of heme, and it's also directed to skeletal muscle, heart, brain for their normal function. But if there is iron deficiency, even before anemia, then those functions can be compromised in order to maintain the red cells. A very important concept to maintain. So let's look at this. And if we can summarize these three groups, these are entities or circumstances or outcomes that have been measured in women who are iron deficient but not anemic. So if we look at the left here is a study that's more than 25 years old and of young adolescents that showed that cognition was impaired by this Hopkins word recall test in these individuals. And in those women randomized to obtaining iron, their recall elevated, as you can see in the red line. And similarly, physical function in these 13 to 18-year-old runners who were non-anemic but iron deficient, their performance improved when they were randomized to iron supplementation and continued to deteriorate when they received placebo. And in this study from Australia, where the vertical axis is a measure of fatigue, you can see that whether you were young or mid-age, if you had ID without anemia, you had greater sense of fatigue. Of course, anemia itself, iron deficiency anemia in this particular circumstance, also contributes to these types of symptoms, perhaps even worse. And this is the SF36 score, and there's a subgroup of these metrics that are related to vitality. And you can see that IDA places individuals into a worse SF36 score than clinical depression or chronic kidney failure or cancer. So these vitality scores are decreased by about 33% from the general population. Finally, in this section, we want to talk to you about the impact of anemia on perioperative outcomes in the non-pregnant individual. So in this study by Toby Richards on the National Surgical Quality Improvement Program sample in the United States, these are women largely undergoing hysterectomy, so it's major surgery. and a quarter of them were anemic. In this group, the 30-day mortality rate was 2.5 times that of the women who weren't anemic, and it's important to know that the risk was not mitigated by blood transfusions. So we can see here in the box on the left, you can see the mortality increase, and you can see the global or composite morbidity increase. And to the right, you can see the various components of that morbidity. So important to understand this because this is behind some of the concepts of patient blood management and why it's so important to have an individual in normal iron balance before getting to the operating room.
Thank you, Dr. Munro. We continue Section 2 with Dr. Derman focusing on the impact of anemia on the pregnant mother, as well as the impact on fetal growth and the child.
We now recognize that the greater the degree of anemia, the more significant are the adverse health outcomes for both mother and baby. And so it follows that women who suffer from either moderate or severe anemia during any trimester of pregnancy are going to have the poorest health outcomes. Anemia is also associated with negative economic impact on the healthcare budget of a country, and it's one of the leading causes of chronic disability in a population. The overall functioning of women with iron deficiency and iron deficiency anemia is known to be reduced. This is especially true during pregnancy and in the postpartum period. We know that women with anemia have weakened immune systems and they're more prone to infection and sepsis. There is also an increase in disability-adjusted life years with consequent absenteeism from the workforce. There are important issues for healthcare decision makers as they consider cost-effective approaches to address an endemic health challenge. When mothers suffer from moderate and severe anemia, fetal underloading often occurs. The developing fetal brain is not immediately able to access iron, which is mobilized first to the reticuloendothelial system. These iron deficits are manifested by a host of measurable adverse outcomes in the fetus and in the infant. Let's now review some of the important negative health outcomes for babies that are linked to iron deficiency and iron deficiency anemia in pregnancy. There's an increase in stillbirth, low birth weight, and small for gestational age infants. We note an increase in stunting. There's impaired neurocognitive development, increases in motor dysfunction, and poor socialization skills. 4 published papers report increases in the risk of autism spectrum disorders and show associations to schizophrenia. Clearly, the impact of fetal underloading not only has a major impact on the fetus and the infant, but also on the parents, the community, and even the economic productivity of a country.
Thank you, Dr. Derman. In Section 3, Dr. Munro will share best practices related to identification and management of ID, IDA, and healthy reproductive age women, and then Dr. Derman will focus on issues related to pregnancy.
So now we're going to move to investigation and therapy of ID and IDA in the non-pregnant reproductive aged woman. And again, we'll conflate the adolescent and the adult. So what's important to understand is that the issues of abnormal uterine bleeding in general, and heavy menstrual bleeding in particular, are highly related to iron deficiency and iron deficiency anemia. So that if you are a clinician and are faced with a woman with the symptom of heavy menstrual bleeding, there's a very good chance that she has iron deficiency and even iron deficiency anemia. Or if you're an individual who encounters a woman who you suspect has iron deficiency or iron deficiency anemia and you demonstrate it, there's a very good chance, if she's in the reproductive years, that that's because of heavy menstrual bleeding, even though she doesn't report that to you. So this means that for women with the symptom of heavy menstrual bleeding, it's important to investigate them for iron deficiency. And if you identify a woman with iron deficiency and iron deficiency anemia in the reproductive years, look very carefully to determine if she has the symptom of heavy menstrual bleeding. And of course, this is incredibly important for the individual who plans to get pregnant, because the periconceptual iron deficiency may adversely affect the pregnancy in general, her experience, but perhaps more importantly, the brain and other structures as they develop in the fetus. So, with that, let's look at how we do this investigation. And in this graphic, you can see that this little dumbbell has at the top the ferritin, the iron stores, and the dumbbell at the bottom is the erythrocyte iron. And the little bar between is what's being transported. They're not in scale, but hopefully they'll help you understand. And so if we look at this spectrum of iron deficiency going from normal over to iron deficient erythropoiesis, you can see the red cells stay the same. So they don't develop anemia until they finally exhaust their iron stores. So we can say that iron deficiency anemia is the endpoint of ID, not the beginning. Let's look at what we can and should measure. So as you can see, even along the top, the erythrocyte morphology, the hypochromia, microcytosis, don't show up until IDA is there. So that morphology has value in diagnosing anemia, but not iron deficiency. And you can see the hemoglobins there going from left to right. And it isn't, of course, until anemia occurs that they're below the 12 threshold for non-pregnant reproductive aged women. The TIBC is frequently ordered, and of course, this is the iron binding capacity. And you can see this gradually elevating until it's very high with iron deficiency anemia. And importantly, you can see ferritin. And the ferritin levels go down, as you can see here, until they're exhausted. So picking up iron deficiency generally can be achieved by measuring plasma ferritin. However, in inflammatory diseases such as IBD, ferritin as an acute phase reactant can be elevated falsely. So other measures such as TSAT, transferrin saturation, may be a better indicator of iron deficiency in individuals so affected. So heavy menstrual bleeding and IDA in the reproductive years, they're linked, as we've discussed. And so these investigations start taking place. The individual seeing a woman with a symptom of heavy menstrual bleeding is compelled to find the cause, and then the management becomes synchronized. You manage the bleeding and the iron deficiency simultaneously. So how do we do that? Well, oral iron, of course, is the first line therapy. And for IDA, about 100 milligrams a day of elemental iron makes sense. And it may even be better to do it every other day, as we discussed, because of hepcidin. Hepcidin is still elevated even at 24 hours. So we have good evidence that alternate day administration is superior even to daily with respect to absorption. And all of those symptoms, nausea, vomiting, constipation, etc., are reduced with alternate day therapy. If you're treating iron deficiency only, one can get away with a much lower dose. There's a much reduced hepcidin response, and so perhaps that can be given daily. Now, intravenous iron is important, and we have for a long time perceived that this is dangerous. And I think we want to put that to rest. Certainly, one starts with oral iron, but IV iron can be indicated when oral iron is poorly tolerated, even with alternate day dosing, or there's poor compliance for other reasons, or the ongoing loss is just such that you can't keep up with it, or there is an immediate need or a short-term need because of surgery, and we discussed why that is important. It's safe. The issues or concerns about anaphylaxis are far overblown. It can be given rapidly. It doesn't have to be given anymore over many hours. It can be given over many minutes. And it has a rapid therapeutic effect. And if we compare it to alternatives, it can be very cost effective. And this means that blood transfusion is rarely needed, except in acute hemorrhagic events. I want to remind you about Professor Richard's data, where those women entering into a major gynecologic surgery and who had anemia had a mortality that was 2.5 times that of those non-anemic individuals, and this risk was not mitigated by blood transfusion. Professor Derman will talk to you about what we know about morbidity with respect to cesarean section.
One of the important themes of this lecture is rooted in the concept that only by screening will one be able to identify who is at risk of iron deficiency and what treatment is appropriate. It is known that when hemoglobin values fall to less than 9.6 grams per deciliter in the second or third trimester of pregnancy, that's the so-called inflection point, use of oral iron can never catch up with the iron demands of the mother-baby dyad. There are a number of reasons cited as to why oral iron is often not the preferred therapy for iron deficiency anemia. Despite the fact that ferrous sulfate has been available globally for more than 150 years, rates of anemia, especially in children and pregnant women, have continued to climb. GI side effects associated with use of oral iron are really common. There is additionally reduced gut motility linked to the high progesterone levels that occur in pregnancy. Adverse symptoms are reported in 60 to 70% of gravidas and account for poor patient adherence. There's also a limited amount of iron that can be absorbed daily, depending on the trimester of pregnancy. And increasing the dose of iron is actually counterproductive because of the modulating effects and half-life of hepcidin. The most recent data would suggest that every other day dosing may be preferable. When appropriate, the concept of employing a single infusion of an IV iron formulation as first-line therapy is becoming well-grounded. All the newer formulations have benefit. More than 100 published papers describe the safety and efficacy of IV iron and its uses associated with a more rapid response than that of oral iron. Rates of cesarean section are increasing throughout the world. In private facilities, especially in low and middle income countries, rates greater than 60% are often the norm. This common operative procedure has been linked to increases in perinatal mortality. We've heard from Dr. Munro of the importance of entering surgery with normal iron stores. This is especially important in the case of cesarean section. The bottom line is that these high numbers of cesarean sections are not associated with any benefit. Much of the additional mortality and morbidity associated with unnecessary cesarean sections is unfortunately iatrogenic. Using new methodologies, including e-partograms, and when appropriate, allowing for a longer first stage of labor before intervening, and supporting ambulation and companionship, all of those initiatives will lead to a reduction in cesarean section and, of course, in intraoperative blood transfusion. We can also achieve a decreased length of stay with its attendant reduced cost to the patient and to the healthcare system. Lowering cesarean sections would also reduce the risk of sepsis, reported to be 2 to 20-fold greater depending on the region of the world. The mean blood loss at cesarean section is reported to be about 1,000 ml, yet many women will have an excess of blood loss beyond that amount and demonstrate clinical symptoms. Not surprisingly, there is an increased risk of dying or of sustaining a near miss. This slide highlights the areas where focused training and technical support can have an important impact on outcomes. Such interventions include improving incision and suture techniques, proper management of the placenta, and determining at what point additional intraoperative procedures might be advisable. The standard use of uterotonics is perhaps most essential, whether it be oxytocin, carbetocin, or misoprostol. Most obstetrical and pediatric societies, as well as the World Health Organization, have supported the implementation of delayed cord clamping. Its practice translates to a meaningful hemoglobin increase in the infant of 0.4 grams at 2 months of age. We are aware that it's not uncommon for infants born preterm to be clinically compromised, yet the practice of delayed cord clamping is often not utilized in those babies for whom it would be most important. Our research team at Thomas Jefferson University in Philadelphia, in concert with Keele University and Karnataka State, South India, have completed randomization of more than 50% of 4,320 women for the rapid iron trial, the largest ever treatment trial of pregnant women with moderate anemia. And I serve as the principal investigator for that study. The study's primary outcome are powered to show differences between users of oral iron and one of either two single-dose IV iron infusions, either ferric maltose or ferric carboxymaltose. Primary outcomes include return to a non-anemic state and the important clinical component of this study, differences in low birth weight. A cost-effective analysis is also being conducted to help healthcare decision makers prioritize whether this initiative should be scaled up. As a follow-up to Rapid Iron, the recently funded Rapid Iron Kids trial will permit us to follow a subgroup of infants through 3 years of life. These infants are the offspring of mothers who participated in the parent Rapid Iron trial. The primary outcome of this rather compelling trial will compare reductions in childhood anemia and report on the rates of neurocognitive change at 2 years of age. It will also employ a validated autism assessment tool at 36 months of age. We have partnered with the Bill and Melinda Gates Foundation to conduct a trial of iron deficiency anemia in postpartum women in 3 continents and incorporating 8 sites. This study is going to be performed at all NIH-supported global research network sites. We know that immediately post-delivery, iron levels are at their lowest. The study will allow us to report on timing and differences among postpartum women for converting to a non-anemic state. We'll also generate results derived from a number of validated quality of life assessments in the mother, and whether differential changes occur by using oral iron or IV iron, and in fact, whether any of these changes have an impact on the infant. To summarize, anemia is highly prevalent both in the United States and globally. Iron deficiency is the leading cause of anemia. The ecology of anemia is multifactorial and includes micronutrient deficiency, inflammation, infestation, and genetics. Despite a 40-year history of providing oral iron as standard of care, we have seen only a 3% reduction in the rates of anemia, considerably less than the 50% proposed as a reduction by the World Health Assembly, which was to be achieved by the year 2025. And so it's time for a paradigm shift to support first-line therapy for single-dose IV iron infusion in women for whom the use of oral iron will not provide the desired benefit.
Thank you, Dr. Derman. In summary, we've covered the following main concepts in this webinar. The adverse impact of iron deficiency and anemia on the global and U.S. population must be brought to the forefront. The prevalence of iron deficiency is unknown, but undoubtedly greater than iron deficiency anemia. Heavy menstrual bleeding is common and frequently the cause of iron deficiency in otherwise healthy reproductive-age women. Both ID and IDA compromise cognition, physical function, work productivity, and health-related quality of life every day of every year. It is apparent that iron deficiency anemia in pregnancy adversely affects fetal growth and development. Anemia in pregnancy is associated with increased risks of adverse outcomes such as preterm labor and perioperative hemorrhage. Normalization of iron balance should start prior to pregnancy in a way that optimizes the intrauterine environment for the growing fetus. One of the common causes of anemia in pregnancy is failure to replenish the iron lost in a previous pregnancy. This process should be planned and underway immediately following delivery. While oral iron can be efficacious in selected circumstances, and in particular with alternate day dosing, failed or suboptimal responses should lead to liberal use of intravenous iron. Thank you to our distinguished speakers, Dr. Malcolm Munro and Dr. Richard Derman. And thank you to the members of the Society for Obstetrics, Anesthesia, and Perinatology who have invested the time to learn more about the prevalence, impact, and association between heavy menstrual bleeding and IDA. At this time, you may take the brief post-test, and upon receiving a passing score, you will receive the CME credit. Thank you for participating in the Society of Obstetrics, Anesthesia, and Perinatology hosted virtual webinar on the impact of iron deficiency and associated symptoms such as heavy menstrual bleeding or abnormal uterine bleeding in women related to reproductive health, pregnancy, and overall quality of life. This has been a CME-sponsored event produced by the Women's Health Research Collaborative, an independent research subsidiary bringing women's health issues to the forefront.